My name is Dharam Kumbani. I'm a fellow in cardiology at Brigham and Women's Hospital, and I am one of the co-authors on this poster, which I'm presenting on behalf of Dr. Bavery, who is the lead author on this project from University of Florida, Gainesville. So what we wanted to do in this study was look at patients with chronic stable coronary disease who also had hypertension from the INVEST trial and see if we could find predictors of long-term mortality, because there are not a lot of good models that predict, when you see these patients, stable patients in clinic, which ones have higher risk and which ones have low risk. And so we looked at the INVEST trial, which, as you know, was a large international randomized trial of hypertensive patients with chronic CAD who were randomized between 1997 and 2003. And they essentially had been randomized to a strategy of a calcium channel blocker and an ACE versus an angiotensin receptor inhibitor. And so this was a sub-study of INVEST. And what we did is we looked at patients within the U.S., so only the U.S. cohort, which was about 17,000 patients, and we had close to 95% follow-up, up to a median of 7.6 years. And what we found is that we had very good power for this endpoint, because 23% of our patients actually died over the course of this period, and so here are the sort of predictors that we looked at. So the usual suspects, we looked at age, gender, ethnicity, body mass index, past medical history, and our goal was to try and see if we can find simple predictors that you could use sort of in your office without getting sort of fancy into a whole lot of complicated calculations, and come up with a simple model. And I think we were very successful in finding these predictors that are highlighted here. So we found age, body mass index, any heart failure symptoms, and stroke, or essentially TIA, to be highly significant with hazard ratios greater than 2, and these are all adjusted analysis. And then in addition, we found diabetes, renal insufficiency, having frequent angina, heart rate, low blood pressure, MI, presence of PAD, and high blood pressure as also to be significant predictors. So I think what this lends itself to is a risk stratification tool, a score, which we believe physicians can use in the office or at the bedside, and more in the office, because these are all stable patients, and then sort of be able to tailor aggressive therapy, statins, etc., high dose statins maybe in these patients, revascularization. So I think that was the gist of our analysis.